Hi, this is Marjorie Morrison.
And this is Patrick Kennedy.
Welcome to the Psych Hub podcast, The Future of Mental Health. Welcome to the podcast. We have another phenomenal guest for you today. You are going to love Patrick Conway. Oh, he is so brilliant, so charismatic, so articulate, and so humble. He is the CEO of Optum Care Solutions, which is part of UnitedHealth Group. Before this, he came from Blue Cross Blue Shield of North Carolina. And before that, he was at the Centers for Medicaid and Medicare. So comes from a really unique lens of both government-funded health programs and private insurance. His background comes from medicine. In fact, he's Harvard trained and did his residency there at Children's Hospital in Boston. And because of that lens, he really looks at everything that he does in healthcare from the perspective of the patient and the perspective of the doctor. So it's really, really interesting to see how he tackles some of these difficult issues. You're going to also get to know a deeper side of him, a more personal one, where he shares about his own struggle with substance use, what he's endured personally and professionally, and where he's at now, which is pretty remarkable. He is doing a lot about changing the way on the future of mental health. You're going to hear the things that they're looking at and really digging in on, such as how programs are designed, how we measure care, social drivers of health, wanting just the clinical workforce to be stronger. We know we have a lot of work to get there, but you're going to love just hearing how he lays out what we have to do, and how lucky we all are to have someone in power be able to have this journey map guiding him as we go. I know you're going to enjoy the show, so let's dig in. Patrick, we are so excited to have you here with us today.
Excited to be here. Thanks for having me.
We kind of would start out with, when it comes to mental health, we think about so many different things, from mental wellness to mental illness and everything kind of in the middle. What would you say have been, to your journey so far, some of the biggest surprises that you have found and learned along the way?
Yeah, I mean, the biggest surprises for me, just over time, is how broken the system is for people, and that it's just not improving as quickly as it needs to be. So I've experiences as a person, as an individual, as a family member, and as a practicing physician. And whether it's substance use or depression, anxiety, or serious mental illness, or any of the mental and behavioral health conditions, our system doesn't get access to people when and how they need it. It doesn't measure and improve outcomes as it should. It doesn't integrate well with primary care and sort of whole person care. And I just think I know Patrick Kennedy has worked on this for a long time, and has driven positive change. He could speak for himself next, but I think for me, I just wish we could improve faster. And the reason I wish that, and that it's surprising that we haven't to date, is it affects everyone across America in some way or fashion. So how do we tolerate a system that is so dysfunctional? And so I look forward, and I'm trying to drive a better system for everyone that delivers the mental and behavioral health care that people need.
It shocks me that there isn't more of a push. I love what you're doing, trying to take your experience, which I think is pretty unique in the industry, having served at CMS and been a government payer, the biggest payer in the country. But, to the extent that you can kind of socialize this concept with your counterparts in the industry, it would be enormously helpful.
Yeah, I mean, I naturally try to drive change. It's sort of my natural personality. So I kid, every strength, by the way, is also a weakness. I probably don't have as much patience as I should. No, I mean, look, I'm going to try to drive for that change and I have tried, both from the public sector and the private sector, as you said. I don't think we talked about this, but a thought experiment for you. Imagine if it was cancer. Would we accept a person with breast cancer where we don't help navigate them where to go? We don't measure the outcomes. We may not cover their treatment. And, we wouldn't tolerate that. Americans would be rioting in the streets that, we got to we got to treat breast cancer better. Yet we as a nation have tolerated in mental health, whether it's schizophrenia or other, a system that doesn't have access, doesn't measure outcomes, isn't paid for some of the time. So it's almost, it makes me upset, mad. I don't know what the right adjective is.
Right.
Because like our system has to do better.
And it's a self-fulfilling prophecy.
Yeah.
If you're not doing those things, then you don't get those good outcomes. And then it reinforces that this field can't really get you better because it's no one's experience that it really works for them.
Yeah.
And then, of course, we don't invest because of that bias. So it really is a circular kind of negative system.
It definitely is. I mean, I'll give you, I learned from a mix of data and anecdotes. So, I was talking to a colleague recently, and they said, well, my mental and behavioral health costs are a small proportion of my cost. And I said, how are you looking at that? And, oh, well, I segment out the mental and behavioral and it's a small part. I'm like, yeah, well, what if you do the analysis a different way? Look at all the people that have physical and mental health conditions. I know you know this, Patrick and Martin. And that's actually driving a huge part of their cost. And by the way, there's evidence on this. Diabetic with a mental and behavioral condition, on average, about 3 times the cost. If it's add a substance use condition as well, can be 6 times the cost. If you treat those mental and behavioral health conditions, we'll bring down total cost of care. We'll have better health outcomes for people, better experience. And so we got to orient our financing and our clinical models, and I know you know this, but around the whole person.
That's
and
right.
That's really in the job I'm working on now. That's what we're trying to do is at Optum really integrate mental and behavioral health care with physical care, where we're delivering whole person care, where we're measuring outcomes, experience, and total cost of care for populations of people.
My political instinct is that if we could hide mental health into diabetes care, into cancer care, into cardiovascular care, so
Right.
we get all of those advocacy groups, which certainly have a lot more power than we do, and make it part of what is expected in the treatment of those other illnesses, and then give them the agenda that this is for more optimal cancer care or diabetes care. We almost do an end run and I think capture the power of those other groups, because I frankly wonder how long it's going to take for us to have enough power to push through what you're trying to do in terms of integrated care if we only approach it from the quote mental health side of the advocacy movement.
Yeah, I agree with you. And I'm hopeful, because I'm naturally optimistic, that this COVID pandemic, there might be obviously horrible, but there might be a positive silver lining, if you will, that it focused people even more on mental and behavioral health care. And I do think, I wish it would move faster, but I think we're trending in the right direction because it impacts so many people. They realize whether it's substance use, depression, and other conditions, we have to have reliable, accessible, high quality treatment. And so, hopeful that we can drive change faster, as you described.
And you were not that far off, Patrick, in what you're saying. I had a conversation with an oncologist the other day, and true story. And he said to me, 85% of his time is spent on mental health. 85. He said literally the chemo that they do and the reviews are pretty simple. It's dealing with the emotions of the treatment, the death, the side effects, and all of that. Yeah. So in a certain sense, it does integrate in everything. We just separate it all.
Yeah, it's totally true. I agree. And I've actually had with some oncologists fairly similar discussions. It gets also to mental health and palliative care. And we, by the way, I think need a better palliative care system in this country that is much more serious illness care across the spectrum. My interest in this area comes from many places, but just to briefly mention on the practicing physician front, I've had many patients that I had challenged navigating the system, but one of the very early ones when I was an intern, first year resident, had a child with adolescent with Prader-Willi syndrome and some medical disease that was treated, had severe mental health conditions, also in foster care, where he then stayed in the hospital for over a year as the system tried to find placement for this child. I mean, think about that.
Wow.
That makes no sense for that child.
Wow.
Makes no sense for our health system. For the physicians and providers, his name was Tommy. I liked seeing Tommy every day, but it literally made no sense. But that's how broken our system is, that the constellation of mental health with social needs meant that we kept a child hospitalized for over a year that did not need to be hospitalized. So just a tangible example of how broken the system is at times.
Would you talk a little bit about the North Carolina models that you are working on in terms of the alternative payment models? I'm just so interested in getting this right financially, because I think the other pieces will fall into place if the proper incentives are established. Tell us about the difficulty kind of getting that going. It's been on everybody's lips for a long time, but trying to accomplish it seems to me has been more difficult than it should be. But
yeah, I learned a lot from that experience. So, we had in Blue Cross North Carolina when I started, mental and behavioral was separated out, as it is in a lot of insurance companies, and actually subcontracted out to a separate entity in our case at that time. We said we wanted to integrate mental and behavioral health care into whole person care. Pretty quickly realized our subcontracted entity would not do that well for us, or not the way we wanted to. So we integrated into Blue Cross North Carolina, led by Dr. Kate Hobbs-Knudsen, who's now working with me at Optum, and did a number of things. One is thought about access and network in a way where we wanted to be able to say any person can get care for any serious illness within 24 hours and any illness within 7 days, in person or virtual. Built out the provider network to do that. We thought about the whole spectrum of disease treatment and condition treatment that we needed. And for example, in substance use, actually launched a company with a partner entity called Eleanor in substance use treatment. Partnered with Quartet, who I know well, on managing mental and behavioral health conditions, identifying people, and integrating that with primary care into whole person care. So we focused on maximizing access, quality, and appropriate treatment across our population. We did, by the way, in the first year, we saw administrative costs go down, and we saw total cost of care go down. We actually even saw mental and behavioral health costs go down because inpatient and residential use went down as outpatient use went up. So the results were positive. We also did value-based contracting, which it sounds like you know about, with mental and behavioral health providers. So let's not just do fee-for-service. Let's do more population-based payment models. We were paying for measuring and improving outcomes over time.
Could you do me a favor and elaborate a little bit about what value-based contracting is for someone who might not understand that, because it's confusing to people?
It is, and people use the term to mean many different things. So the way I described it is a spectrum. So there are some contracts where it's, what I'll call pay for performance. You may get some incremental small incentive for a quality outcome. On the other end is sort of full population-based payment, meaning I literally say, I'm going to pay you, X dollars per month adjusted for quality and experience, and that's going to be a monthly payment. And then in the middle, which is actually where we landed in mental and behavioral, is significant incentives. I'm going to pay you X dollars per member per month to achieve these outcomes. As long as you do that and you do well, that payment will go up. If you don't do well, that payment will go down. But you align the incentives in its core with what we want for the patient population, which is better quality, better experience, lower total cost of care. Sorry, I'm passionate about this, so I'll try.
No, this is great.
Our current fee-for-service system, if you run a hospital and there's a readmission, that's more revenue. Like, that makes no sense. No one would want that incentive in place. Hospitals hospitalizations, more revenue. I work in hospitals. I've never met anybody who wanted to be hospitalized. It's literally never happened to me. They want to get home and stay home. And so when you have a value-based incentive, it will be incentives to prevent hospitalizations or to prevent readmissions. So that's the core of what we're trying to do with the payment incentives.
When you think about achieving the value, you have to know what you're measuring against in order to know whether you're achieving the outcomes. Can you talk a little bit about maybe your thoughts on what those markers look like, but moreover, as an industry, whether you think other payers and Optum can get to a point where you kind of agree on a common set of outcomes in this mental health and addiction space such that we can really know what we're talking about and having a common nomenclature in describing what we're after?
Yeah, I do think both in the public and private sector, we should commit to common measures. I led some of this work at CMS. I remember a meeting with you where said, we need to measure PHQ-9. We need to measure a set of, patient-reported outcomes reliably across our systems. We need to implement collaborative care. And so with our team, led that work at Medicare. Similarly, in Blue Cross North Carolina, it's actually in public and private payer interest to have aligned quality measures, because then providers have an aligned set of incentives and measures. And so that being said, to your point, we're not there yet. It's unfortunately still the case that too many payers have different quality measures. And often we, especially in mental health, may not even be measuring, as you know, patient-reported outcomes and other evidence-based measures. So I think we've got work to do to embed that, if you will, in all of our payment and clinical systems.
Well, again, I hate to beat up on AHIP, but they have an enormous opportunity and a window of time to really press CMS to adopt some basic outcomes-based metrics that all of them can agree on are good for everybody. And I certainly hope that they get about doing that, because if you miss the chance when it comes around, it's just a real lost opportunity. And so I implore you, anything you can do with your colleagues in this space to say that this is possible. You were there at CMS. You were at CMMI. You know what is possible if you have the right political pressure placed on the powers that be, which you respond to at CMS, because you serve the broader public. Boy, that would be a huge, powerful achievement.
Yeah, no, I totally agree. And I will keep pushing in that direction. And I think it's the right direction.
So could you talk a little bit about how technology, insofar as like these biomarkers, that technology through voice, facial recognition, these apps, the equivalent of a Fitbit, how your phone can start to allow for sensors, how that stuff can be integrated that will enhance the chronic disease management of both mental illness and addiction, and also help you risk stratify who you need to intervene with and when.
Yeah, so I think we're sort of scratching the surface of, if you will, of the impact here, and have learning to do. So, and we're trying to do that through a series of pilots across different states and communities. So, for example, MindStrong is an Optum venture-backed company where we're testing them in some of our areas. We're in discussions with a number of companies that either have apps or biomarkers or digital technology that we're, how do we test these in different patient populations, see if they work in terms of better outcomes and lower cost, and then deploy them at scale. In the telehealth virtual space, we also have Able2, which is cognitive behavioral therapy via telehealth and virtual means, evidence-based measures, patient-reported outcomes shown to improve outcomes and lower total cost of care. And we're deploying that across our system. So, I think it's a burgeoning area, if you will, with real opportunity. Some of it actually blows my mind. Like, you watch somebody and how they type on a phone or how they talk, and you can like make a diagnosis, which they didn't teach me that in medical school, I'll tell you that. But I love innovation and creativity, and so to get to break through the next phase, if you will, of prevention, diagnosis, and treatment in mental health and brain diseases, I think we're going to have to tap into these new technologies. So I'm incredibly excited about the future there.
And it really allows us to bring to scale quality care without having it be really prohibitively costly. If you did asymmetric kind of asynchronistic kind of evaluations, like you point out, of an interview, if you're doing telehealth session, you could have psychiatrists kind of review that, in total, in a very efficient way. They could back up or reinforce whatever the paraprofessional or on-site clinician, is evaluating. And it's not a case of everybody sees a psychiatrist, but everyone gets seen in a timely way. And you don't ignore the value of having a psychiatrist do this asynchronistic kind of evaluation, with the point that you're making, that it's almost like subtitles. It can kind of look at the facial recognition and the voice and tell you, are they lying about being depressed or anxious? And then it gives you a chance to get to the heart of it, because so many people, just their inclination is to hedge, qualify their stories, really not tell everything, because just that's the culture we live in.
Yeah, that's right.
Patrick, yes, I say two Patricks, Patrick and Patrick Conway. We've been talking a lot about this kind of spectrum of mental health, right? And this journey that everybody falls onto this continuum somewhere from, just real mental wellness to mental illness, and somewhere in the middle, and that all of us are on this spectrum, every one of us. And we talk a lot about, it's very normal to feel depressed and to feel anxious, and that can be healthy too. And that also helps you grow and learn for those good times. And that, there's a couple different things, I think, going on. On one hand, we have a stigma issue that people talk about a lot. And then on the other hand, less popular to talk about, we have a very highly diagnosable population of people who have been diagnosed and have kind of owned this diagnosis, and now they feel like it's almost inhibiting to them. And so there needs to be some work, I think, to have people live within these kinds of conditions as just everyday life. So with that, I mean, all of us have this journey. What's brought you here? What's made you passionate about it? And what are your thoughts about this kind of this continuum?
Yeah, man, that was really eloquently stated. I've thought about this continuum a lot and the journey, and I'm still on my journey, if you will. Certainly worked in this area for a long time. Had both as a practicing physician and family experiences that shaped that, as we all have. And then just to talk a little about my personal narrative, I mean, the consequences of my substance use were very public in North Carolina. So actually called Patrick Kennedy in June of 2019. And so, what that led to was a major negative impact on me and my family. On the positive attribute side, what it also led to was me making changes in my life that I'm healthier than I've been in 20 years. So lost almost 50 pounds through diet, exercise, other changes. I was on 2 blood pressure medicines and cholesterol meds. I'm now on nothing, and reflux meds. So I'm on no medicine, knock on wood.
Wow.
I meditate regularly, which I knew was health beneficial, but had never done in my own life. And sought the support I need, both personally and from a family support framework. So, I and our family is in a much better place today than I was 2 years ago. And it is a spectrum. It wasn't, I've been blessed in my life. I've had a lot of positive, amazing positive things that have happened to me. I also learned, quite frankly, even navigating the system for myself was challenging. I've had to do it as a person, a family member, and a physician, and it's almost uniformly been challenging. And if it's hard for me, that's a really bad sign for the rest of America, because I'm in the health system. And so, the point is not about me, it's about the system. How do we make the system better for everyone? So navigating the mental and behavioral health system is easy. You get the right care at the right time. We intervene before somebody is in crisis and has major impacts in their life. And that we, as you said, reduce the stigma, talk about it openly, or eliminate the stigma, talk about it openly. And I'm still on that journey. I have more to learn on a personal level and a professional level. But that's what I would share about my journey.
Well, as a friend, but also as a politician, you would have been such a powerful advocate for all that you were trying to accomplish in North Carolina if you had had more enlightened people who were saw this as the opportunity that it ultimately became for you, where you could tell your own story, immediately get a buy-in at such a deep level when it's hard, I'm sure, as an insurance executive, getting providers to actually work with you, to getting communities to trust a payer. If you had been able to take that experience and say, not only is this the right model financially for our company, it's the right model for North Carolina. And this is important to every one of us. And I can tell you from my own experience, this is the way we need to go. I am telling you, what a major missed opportunity. I go back to these missed opportunities. Blue Cross North Carolina and the leadership at the insurance commissioner and everything made when they decided that this was going to be something that pushed you out. Of course, in my life, my DWI almost pushed me out, but then something happened. I remember on election day, I was standing out in front of the polls and someone came up to me who I knew didn't like me. I knew they didn't support me. And they said something that shocked me. They said, Patrick, in this election, I'm going to vote for you because I've got addiction in my family. And I know you know something about this on a personal level. And it's about time some of those colleagues of yours understand this. And you're the right guy to bring the message to Washington. It was 10:30 in the morning. I knew I'd already won the election, because if it had been able to be transmitted to folks in a way that was connecting as opposed to alienating, it changed the whole dialogue. Can you talk a little bit about how you see kind of the spiritual component of this world of medicine? Like, you talked about meditation, but where does that piece of it, especially since so many people, no matter whether it's a mental illness or addiction, particularly with addiction, this component of belonging, connection, community is not just a quote social issue, it's a spiritual one.
I'll stick with the personal and then go to the broader frame. On the personal, in my own life, spiritual component and the higher power component is incredibly important. And for me, I grew up in the Christian faith, and still that is a huge part of my life. And it's a huge part of our family's life. And I truly believe that, and this going through challenging times, especially, but in all times, that's what guides my life. And so, do I always live up to it? No, it's a journey for everyone. But that's the North Star, if you will, for me and our family. Then I think there is evidence on this, as you said, that the spiritual component is important in mental and physical health. And that spiritual component, if you will, can come in lots of different ways. I mentioned my faith, but it comes in all types, whatever that spiritual component is. And meditation, interestingly, and not to keep pushing on this, but I literally, because I'm into data, I routinely can meditate and get my heart rate into the 40s. That's physiology. Wow. That's like I've gone to a place where my physical body is able to, and that, by the way, I couldn't do that when I first started, and sometimes I still can't do that when I'm not fully centered, if you will. But that's a physical effect, right? I mean, we know this. And so, I think it goes back to how do we build a system that through different supporting mechanisms, many outside of traditional healthcare, supports people in their own journey and their own health for the long term. Sorry, long answer. I was recently talking with the Whole Health Institute, which got sponsored out of the Walmart family. And I think there's lots of people doing interesting areas that work in the space, but I think there's some real opportunities for whole health focus that I know, Patrick, you have championed for a long time. I think there's more people, hopefully like you, coming along that champion this whole person, whole health framework, because that's what we need.
Can you talk a little bit about cultural competence, and particularly at this significant moment in race relations in our country and the recognition amongst the majority population as to the sheer violence and trauma that affects people with a different colored skin from a different background in a way that we often don't identify with because it's not our shared experience, and the need, if we're going to do mental health right, to have an appropriate number of culturally competent providers to deliver that care.
Yeah, I think there's an increasing recognition of the importance of cultural competency for clinicians and other providers. So a lot of work to do, but I think there's an increasing focus on training, education, measuring that, improving that over time. This also gets, by the way, to issues of, we would like the clinician workforce to be representative of our nation, and we've got work to do there as well. The health equity issues, and I do think of them as health equity. I think there's good evidence we have significant work we need to do. I mean, you have populations of different races and ethnicities that have systematically worse health outcomes in our system. Like, that has to change. We have to build a system that truly produces health equity, which cultural competency is certainly a large part, but it also gets to everything from trials and how they're designed to how we implement evidence-based treatments to how we measure care to social drivers of health. So this has been a focus of mine for a long time, continuing into Optum, where this focus on health equity and what are often called vulnerable populations. How do we make the investments to support those populations?
I have a friend who it was kind of a high up at the VA, and she traveled to North Carolina when you were there to hear you speak at something. And she called me after and said, "Oh my God, I've just heard this man. He's so inspirational, so incredible. I swear I'd quit my job in a second and come work for him. And he's just..."
She should have done it.
So I ask you, I have heard that you made a promise to your father that you were going to devote your life to fixing healthcare. So I'm wondering.
Who told you that?
I have inside information. I was just wondering if that's where that's kind of inspiration comes from.
Yeah, no, it's funny. That is true. People often ask, I'm one of 4 children. My 2 older sisters are doctors. My brother runs global public health for McKinsey. Our family did not tell us to go into medicine, so I don't know. But no, when my father, a few days before he died, I still have trouble telling the story, asked me, what impact did I want to have? And we had talked about this before, and I said, well, I told you, Dad, I want to change healthcare in America for the better. That's the goal. And he looks at me, and this is classic my father. He says, Patrick, that's a very, very hard goal. I'm not sure if anybody can do it, but he's like, if anyone can, it's probably you because you are very persistent, which actually is true. I am very persistent. So whether it was CMS or my current role, I mean, like, I just keep going after the change that I think needs to happen, which overall I think is a good attribute. It sometimes probably throws people off a little bit. My teams always kid with me. They're like, they know the question I'm gonna ask. I'm like, can we do that faster? Can we do it quicker? And I do actually hire people over and over again. So, which has helped me in life. So I kid with people. Greta, chief of staff, is right next to me. I'll tell her right now. I'll pre-warn her. I've already warned her. Like, one time, somebody. I plan to like keep you with me forever. So you set me up for a long time frame.
I can't thank you enough for your persistence, because I know, and Patrick Kennedy, I know, agrees with me. We really need you. We need you, and we need people like you who are just breaking glass and just trying to, push the envelope, but doing it smart and doing it, the right way, and how you started, which is, that you did it already, where you can prove that you can get better outcomes, and those better outcomes give better quality life, give a better member patient experience, and they also reduce the total cost of care. So it all makes sense. And I think why we're doing this podcast is really to educate the public about where do we need to go and why do we need to go there. And most people don't understand it. It's complicated when you're in it every day. It's obvious, but when you're on the outside and you don't understand why your healthcare is so expensive, and why your copays and your deductibles are so high, and why it's costing so much money, it's confusing, and it's broken, and there's no other way to sugarcoat it. It's completely broken. Yeah. And so I really appreciate that you lead from a personal experience, but you are not slowing down.
Yeah. Look, in my current, I appreciate you saying that, and certainly all the work that both of you do. Thank you. In my current role, because I haven't probably talked about quite, we would like to build the highest quality, most evidence-based, accessible mental and behavioral healthcare delivery system this country's ever seen. Like, that's the goal. It's a big goal. We've got a long way to go. But I think, that's the journey we're on. Our goal is to build out and when I say build, it's not just, through partnerships, through relationships, through also buying and building, but through all mechanisms, build out a system that provides that level of care. And that, that's the opportunity. I mean, that's why I know why you do the work that you do. That's the journey I'm on with our team is, we want people to get the care they need, when and where and how they need it. And for that to deliver better outcomes. So it's a little bit of but just, that's our goal. That's what we're working on.
And
so
we
one
know
of the things you did in North Carolina is really reach out to the major employers and enlist the business community who has a huge fiduciary interest in getting this right, not only for their healthcare spend, as you said, but also in terms of minimizing their liabilities with absenteeism, disability, and presenteeism. But unless these people you work for, the companies that you provide insurance for, they're engaged, you're never going to get them to see the twofer in what you're doing. Tell us a little bit about your experience. You're not in the sales side, but from what you're hearing, I'm sure post-COVID, it's going to be astronomically higher, but are they getting more engaged, the national business groups on health and so forth, in what you're trying to do over there?
They are getting more engaged. I would encourage you from your vantage points to continue pushing on that engagement. I think employers are getting more engaged. Mental health care is a major pain point for them for the reasons you described, both in their healthcare costs, but in their workforce productivity, et cetera. And they're hearing it from their employees, that this is the major health issue. So we are hearing that. We're working to address that with employers. We're working to, as I said, have accessible to a high quality, evidence-based mental health treatment capacity, both virtual and in person, for the whole spectrum of conditions. But I would challenge the business community. I did this a lot when I was at CMS. I would like them to get even more engaged. Like, they are the buyers of health and healthcare. Right. And so please, clearly, I hope they, together, they have their voice heard, that they want a better mental health system, and quite frankly too, they're willing to make the investments, if you will, too, to make that happen with others. But they have to be part of the equation to deliver that better mental health system that we all want.
Well, Dr. Conway, it's really been awesome catching up with you again. This was a terrific opportunity for people to learn that there are real people behind these massive organizations that are working to fight to make things better. I always found when I was in Congress, people didn't know what incredible human beings were there, what real public servants, because they just hear all the negative. And I think in one small way, you've helped people understand that they're great people behind all of this. And I think that's good for all of us. So thank you for joining us in this podcast.
And I would just add too, from the Optum perspective, here at Psych Hub, Optum believed in us early. They have been really one of our closest partners, and we've lived it. We've lived this really cool experience, getting to do innovative things with many different branches of United and Optum. And so we're also just very grateful for the opportunities at Psych Hub that Optum has given us. And we do work with, and we love all the payers because we work with them all, but really Optum was in early. And so I think it's a good place that they, we always say things work out the way they're supposed to, but it's nice that you landed there, because I think that there's some great stuff that you'll be able to do there.
No, thank you both. I'm incredibly excited for where I am and the work that I'm doing with the team here. And thank you both for having me.
What's cracking, Hope Nation? It's your friendly neighborhood Kevin Hines, and here's your Psych Hub brain health tip of the week. Reciting, repeating, and believing. A mantra akin to I am worthy, I am enough, I am wonderful, I am great. Experts say that reciting and repetition creates a physical relaxation response. Sit quietly and pick any meaningful or soothing word, phrase, or sound. To get started, you can set a timer starting out at 3 minutes, and you can increase your duration over time. It doesn't matter how long you do it, it's more important to incorporate it into your routine, your daily routine. You can recite and repeat the mantra aloud or silently. Remember, if your thoughts wander, acknowledge that thought, let it go, and pick the mantra back up and recite, repeat. It eventually then becomes something you believe.
As always, thank you for listening to our podcast.
If you enjoyed the show, drop us a review.
If you haven't already, subscribe to our podcast for the latest episodes.
For the latest insights, check us out at psychhub.com.